Hi, welcome everyone to our today's weekly research conference as we celebrate the International Women's Day. Certainly, I was most proud of our women team members who are leading, participating, or supporting our research endeavors here at the University of Ottawa Heart Institute. And despite challenges of the pandemic, which we really force all of us, trying to balance multiple roles, the accomplishment of our women researchers have been simply amazing. And so before I introduce our esteemed speaker today, just a few logistics. So make sure you submit your questions using the Q&A feature, not the chat feature, and they'll be answered at the end of the presentation. But feel free to submit your questions as the presentation is proceeding. And we will actually also have some trial poll questions for this presentation, and the Kerri-Anne will be able to work with you on that, and we'll see how that goes. And we'll also be accepting live questions at the end of the presentation. So please use the hands up feature on the bottom of your screen. You'll be asked to unmute by the moderator, and you can ask the question in person. On the other hand, if you have any technical issues, please use the chat feature, and Chelsea or Allison will be able to work with you to make sure you can join successfully. We are absolutely delighted today that Dr. Kerri-Anne Mullen as our speaker for this special International Women's Day rounds. And as she's also director of our Canadian Women's Heart Health Center at the Institute. She's also a scientist at the University of Ottawa Heart Institute. Most notably, her team has worked tirelessly with hundreds of health care organizations, both near and far, to implement and evaluate clinical approaches to the treatment of tobacco addiction, one of the world's top public health challenges. This is often referred to as the Ottawa Model of smoking cessation, continuing the pioneering efforts from Drs. Bob Reed and Andrew Pipe, amongst others. Kerri-Anne received her BSc from the University of Ottawa, her MSc at the University of Illinois, Urbana-Champaign, and her PhD at the University of Ottawa in the School of Population Health. She also trained as a junior scientist at the Institute of Clinical Evaluative Sciences between 2010 and 2015 within the primary care and population health research programs. Dr. Mullen was the recipient of the Canadian Health Foundation of Canada's Graduate Research Award in 2012, and also she received a 2-year CIHR fellowship in population intervention for chronic diseases in 2009 to 2011. Her research really spans the entire spectrum of health services, economics, and health impact of prevention intervention with a focus on smoking cessation. And she was a member of the board of directors, Canadian Association of Cardiovascular Prevention and Rehab between 2011 and 15. And she also chaired organization committee for its successful annual meeting in 2012. She has also chaired and assisted on several tobacco cessation committees at the local and the provincial governmental levels. And for her work, her accomplishment, Kerri-Anne and her team, and the Ottawa Model for smoking cessation was awarded the Heather Crow Smoke-Free Ontario Award in 2016. So we really look forward to Kerri-Anne's presentation today. It's entitled From Bedside to Worldwide, How the Ottawa Model Bridged the Death Valley of Knowledge Translation. Kerri-Anne?
Thanks very much, Dr. Liu, for that kind introduction. And hi, everyone. Thanks for joining us today on International Women's Day. It's my pleasure to be with you to present this presentation. We were just talking about this image that's kind of faded back there, and Dr. Liu said he's actually been to the Death Valley. I have not conquered Death Valley in the true sense, but certainly in the metaphorical sense. We'll talk today how the Ottawa Model bridged the Death Valley of knowledge translation. Yeah, I'm going to give you a sense of some of the research I've been involved in that's really been embedded within the story of the Ottawa Model for smoking cessation over the past 15 years. Since knowledge translation's in my title, I thought I better show the good old knowledge to action cycle. And this is probably familiar to many of you, but it really starts at the bottom here with identifying a problem. And it's identifying and reviewing the knowledge, what is known about this problem, which then leads to sort of adapting the knowledge to maybe the local context, assessing barriers. What are the barriers to using this knowledge? It then leads to the development and implementation of interventions. And going along through this cycle, it's about evaluating those interventions and hopefully sustaining this knowledge use. And so hopefully, as I go through my presentation, you'll see how a lot of the research, the Ottawa Model for smoking cessation was really built on the principles of knowledge translation, or at least it certainly evolved that way, to lead to some sustainable program implementation and certainly expansion across the country beyond the walls of this institute. And so, starting at the bottom here of identifying the problem, what was the problem for the Heart Institute? The problem was tobacco use among our patient population. And at the time, about 5 million Canadians were current daily cigarette smokers. And when I say at the time of Ottawa Model being developed about 20 years ago, and tobacco use today still remains a leading cause of premature death worldwide and in Canada, and a leading cause of hospitalization and rehospitalization. So for our patients who smoke, helping them to quit smoking or smoking cessation is one of the most, if not the most important intervention we can provide for those patients. Whoops. Let's go back to my presentation. And back in those days, as I said, about a quarter of all of our patients, our inpatients, were current cigarette smokers. Smoking rates have fortunately gone down over the years, but this was a significant problem among a significant proportion of our patients. The Heart Institute has been providing smoking cessation support in our community since the 1990s through our outpatient quit smoking program. And this is a program that we continue to operate today. This program sees about 200 to 300 smokers and provides one-on-one counseling with nurse specialists and has fairly high success rates. But as the story goes, in the early 2000s, Dr. Bob Reed and Dr. Andrew Pipe were having lunch in Tickers. And now early 2000s, I was still just a young pup completing my undergrad. But so I've only heard this story through their perspectives. But they were having lunch. They were sort of doodling on the back of a napkin, as they'll tell the story, and said, well, isn't it great that we can provide smoking cessation support to 300 people per year? But what about the 2,000 smokers that are admitted as inpatients to our institute every single year? We could be reaching 10 times the number of smokers and providing support if we actually brought the intervention to the bedside. And so that really started the idea of the Ottawa Model and started the research involved in collecting the knowledge and the evidence of what did we know about hospital-based smoking cessation. And at the time, really, there wasn't a whole heck of a lot. But this is sort of where things started. All good ideas start at Tickers, I guess. That's your first takeaway. So the Ottawa Model, what is it? For those of you who may not know, really it's a clinical protocol that involves the systematic identification and documentation of smoking status of all patients. And believe it or not, we were not asking patients if they smoke 20 years ago. So we systematically identify and document. For patients who do smoke, it involves offering a brief consultation, which gives them practical advice on how to quit smoking, and offers pharmacotherapy to help with nicotine withdrawal while they're in hospital, and then also a prescription for pharmacotherapy to use beyond the hospital stay to help with a long-term quit attempt. And then finally, it's attachment of patients to long-term follow-up support. In 2006, the team published the first evaluation of the Ottawa model. So there they are, Dr. Bob Reed on the left, Andrew Pipe in the middle, and Bonnie Quinlan on the right, who at the time, Bonnie was our advanced practice nurse in smoking cessation. And the team published the results of the first evaluation that assessed the effectiveness of the program at helping people quit smoking. And so you can see the results here. In the green bar, this is the control group. And these are patients who did not receive the intervention. About 30% of those patients were smoke-free when we followed up with them at 6 months, compared to 44% of patients who were smoke-free and who received the intervention at the bedside. And so the folks who received the Ottawa model were an absolute 15 times more likely to be smoke-free at 6 months. So this is great. This was the first evidence that we had an effective intervention to help our hospitalized smokers. 2006 is about the time I just completed my master's training at the University of Illinois. So it's funny how life works, and timing is sort of everything. I can recall applying to a research coordinator position at the Heart Institute when I had just moved back to Ottawa. And I think it was in cardiac rehab or in exercise, but I got a call back to interview for a research coordinator position in smoking cessation. And I thought, what do I know about tobacco addiction? I know about other sort of health behavior change, but nothing really on nicotine addiction at the time. But I thought, what the heck? I went to the interview, and it was actually Bonnie Quinlan who interviewed me and hired me for my first job at the Heart Institute. So I was hired to work as a coordinator on another project. Meanwhile, the team had just secured the first grant to expand the Ottawa model beyond the Heart Institute and start working with other hospitals in the Champlain-Lynn to help implement the program in other hospitals. And so within a couple of months of being hired, I was actually then hired as the first outreach facilitator that we now call implementation specialist, to work with other hospitals to help them implement the program. And one of my first tasks as outreach facilitator was to actually work on this, the implementation guide that would assist us in helping other hospitals or other settings adopt the program. So this is sort of a schematic of the implementation guide that is still used to this day to help other sites implement the Ottawa model. You can see it starts with phase 1, introducing the program, gaining buy-in at an organization. Phase 2 is a pre-implementation evaluation where we assess, what practices does a site already have in place with regard to smoking cessation. Phase 3 is program planning and protocol development, and this is the bulk of the work. This is really where the Ottawa Model clinical protocol is adapted or developed for a local site, and all the sort of clinical tools that go along with that are also adapted. And not until that protocol is in place do we then train the staff. So phase 4 involves training frontline staff, but other staff on the principles of the model and how it actually works. Phase 5 is launching. And then phase 6 is our post-implementation evaluation, which is sort of a continuous quality improvement cycle that then begins. So while, this implementation, this work is not pure research per se, we had built into the implementation at every site this pre-post evaluation. And so which allowed us to be able to evaluate multiple components of the program, both at the patient level, but also at organization level, which really, became the framework for sort of the research that we did within the program. So as I said, once we started taking it to other hospitals, and the Champlain LHIN was the first sort of other region of Ontario to adopt the Ottawa model in other hospitals. And we published in 2010 a meta-analysis of an effectiveness study of the first 9 hospitals that had implemented the model outside of the Ottawa Heart Institute. And so on the right here pictured is Debbie Aiken. Many of you will remember Debbie. She retired a couple of years ago, but she was certainly my partner in crime in those days, as we put a lot of miles on our vehicles driving around the Champlain, helping hospitals implement the program and training staff and so on. But what this evaluation found, or this meta-analysis of these first 9 hospitals found, was that we saw once again, significant increases in 6-month smoking status among patients who received the Ottawa model in hospital. And this time, these were general hospital patients. These were not cardiac patients. So you'll see that the quit rates are slightly lower, but cardiac patients tend to be slightly more motivated to do something about their smoking. In a more general hospital population, we were seeing, patients coming in for all sorts of conditions. But nonetheless, an 11% increase in quit rates is a highly significant outcome. The minimal clinically important difference that we look for in smoking cessation trials is around 5%. So anything greater than 5% we feel is a huge success. So here we were building the evidence of the effectiveness of the Ottawa model. So, all right, it's efficacious, it's effective. Then we were starting to get questions of, well, is it cost effective? And does it actually improve lives? And so, we were up for the challenge. So we said, all right, well, let's find out if that's the case. And as part of my doctoral training, I was able to study as a student scientist at ICES, and we embarked on this study, which was looking at the health and healthcare outcomes following participation in a hospital-initiated smoking cessation program. And on the left there in the glasses, that's Doug Manuel, and Doug was my PhD supervisor, and he is a ICES scientist. And to his right is Steve Hawken, who's also a scientist there, and it was really helpful in terms of the methodology. And then to their right is Doug Coyle, and Doug Coyle and I got to hang out quite a bit. He's a health economist at University of Ottawa, and I learned everything I know about economic analysis or cost-effective analysis from Doug Coyle, although he may not want me to tell you that. But these were really important studies. We had a number of economic and health services studies that were really important in terms of demonstrating the impact of these hospital-based smoking cessation programs. So our data linkage study at ICES, this is what we did. At this point, we used data from 14 hospitals that had implemented the program. 641 participants were recruited for a control group. And these were inpatients who smoked, who did not receive the in-hospital intervention. 726 participants were recruited for the intervention group, which in this case was a group that received the Ottawa model. And then we linked their individual data to health admin data at ICES and followed them for 2 years to look at these outcomes. Our primary outcome was all-cause rehospitalization. We looked at smoking attributable rehospitalizations, all-cause and smoking attributable emergency department visits, mortality, and cost. And again, we looked at these over a 2-year period. The type of analysis we used was competing risk regression. And what this analysis does is it calculates a cumulative incidence function. So it looks at the probability of an event happening before a given time, but it also deals with the competing risk of death. So for example, when we looked at rehospitalization as the outcome, once someone dies, they're no longer at risk to be rehospitalized. And so this test sort of deals with that competing risk of death. And then to look at healthcare costs, we use linear regression. So what did we find? At first, we looked at the 30-day period because 30-day readmission to hospital is an important healthcare indicator. And what we found was that participants who received the Ottawa Model intervention were relatively 46% less likely to be readmitted to hospital for any cause. And you can see below there the absolute risk reduction of 6% and the number needed to treat being 16. So what that means is we need to offer only 16 patients this in-hospital cessation intervention in order to prevent one rehospitalization in the 30-day period. When we looked at smoking attributable readmissions, so for conditions that are causally related to smoking, we found a similar reduction in those readmissions. And when we looked at emergency department visits in the 30-day period, there was a 22% reduction for those who received the Ottawa Model intervention and significant absolute reductions as well. So then we looked up to the 2-year period and at the same outcomes and found similar results, but actually an even greater effect when you look at the absolute risk reductions at 2 years for all causes smoking-related readmissions, 12% reductions, 11% in smoking-related readmissions, and the number needed to treat now to prevent one hospitalization over 2 years is 7. The results for ED visits were attenuated a bit, although still significant and still reduced for those who received the Ottawa Model intervention. And the most important finding of this study, and I guess surprising finding, was the effect on mortality. The patients who received the Ottawa Model were 48% less likely to die over the 2-year period. And that's an absolute risk reduction of 7%, which is, you know, a huge effect with a number needed to treat at 14. So this study was sort of confirming what other studies had shown in the impact of providing smoking cessation support or the impact of quitting smoking and what it has on someone's short-term but even up to 2-year long-term health. When we looked at the per patient cost over the 2-year period after we intervened with the patients, the participants in the Ottawa Model group cost on average $4,000 less to the healthcare system over 2 years. And these are crude numbers, but nonetheless, you know, I think it demonstrates the potentially huge cost savings when we can actually help someone quit smoking and the benefit that has in terms of their future healthcare use. So, you know, building on the story, we started off showing that this model was effective. Now we had data to demonstrate that it was cost effective and it actually was improving lives. And so, you know, this was sort of helping us build the business case when we were trying to work to implement this model to a greater scale in other types of settings across the country and beyond. But if you'll humor me for a moment, I might make a little editorial note. And this is actually a quote from one of the discussions from an economic analysis paper we published in 2015. An estimated $500 million is spent each year in Ontario on hospitalizations for myocardial infarction, unstable angina, heart failure, and COPD alone. And in this study, those are the 4 conditions that we had completed the study on. Our study estimates that providing the Ottawa Model intervention to smokers admitted with these conditions would represent 0.2% of this cost, yet could result in actual cost savings. There's an apparent expectation of behavioral or preventive interventions, including smoking cessation, to demonstrate that they are cost saving or able to save lives with little investment. By contrast, this requirement does not exist to nearly the same extent when it comes to other medical or procedural interventions for chronic diseases. And it's in our opinion that cessation interventions, and I would argue other prevention interventions, should be adopted regardless of their ability to save money. I'd like to add, I'm really grateful to the Heart Institute leadership for recognizing the importance of prevention and making it a priority, and and investing in prevention interventions and really supporting the work that we do, because it's not every institution that prioritizes it in quite the same way. So thank you for humoring me. All right, back to the presentation. So in terms of this is a common equation for sort of looking at the impact of population or public health interventions. And you can have a really highly effective intervention, but that you're only able to reach a few people. And so the overall impact of that intervention may not be quite as large. And so one of the things we always, one of the objectives or in the back of our head in sort of developing our projects, and certainly the Ottawa Model, and as far as its knowledge translation plan, was to just reach more smokers. We know this is effective. We know it's cost saving. How do we reach more patients who smoke with this intervention? And so the next series of studies I'll show you have kind of focused on that, looking at different strategies for trying to increase reach. And so this actually was published very recently, and this is a study that looked at a policy level intervention that aimed to increase the reach of smokers in hospital-initiated smoking cessation interventions in our region. And so I'd like to highlight in this case, Kate Walker, who's in the left. Kate is a PhD candidate and trainee in the Division of Cardiac Prevention and Rehabilitation, and was really instrumental in helping to write this paper. In the middle is Laura Hovler, and Laura and I were sidekicks for 10 years or more. And she is like the behind the scenes whiz, and knows, keeps everything sort of going, all things Ottawa Model concerned, but is the keeper of the data. So Laura really has been, instrumental in all of our evaluations. And of course, on the right, you'll recognize Dr. George Wells. And I really need to thank Dr. Wells, who's been, an incredible mentor for me, and has really helped with a lot of our evaluations. And in particular, George was really helpful in helping on the design of this evaluation. So let's have a look at this policy level intervention. In 2010, the Champlain-Lynn added a performance obligation to the agreements it had with 15 of the hospitals in our region. And what was expected that this obligation outlined that hospitals were to ensure provision of the Ottawa Model to patients with the expectation that the intervention would be provided to 80% of inpatient smokers by March 2013. And so backing up to prior to 2010, when we had started working, when Debbie and I got in our cars and were driving around the Champlain-Lynn helping other hospitals implement, it was completely voluntary. We had actually just sent emails out to the hospital CEOs in the region to say, hey, are you interested? We'll help you implement a smoking cessation strategy for your inpatients. So just leading up to 2010, it was voluntary implementation. And then the Lynn stepped in and said, this is an important enough intervention. We want all hospitals to be doing it, and we want to set a target of 80% of smokers reached. So for this study, we used the RE-AIM framework to sort of evaluate the implementation. And we have used RE-AIM in a lot of our program evaluations. And from an implementation science standpoint, it's, in my mind, a really great framework to sort of guide the evaluations. So we measured reach. That was our primary performance indicator. How many smokers were hospitals reaching? We measured effectiveness, adoption, and implementation before and after the new policy and the new agreements were put in place. And we used an interrupted time series design to measure the effect. So here you can see between 2007 and 2009, and this was again that sort of voluntary period when hospitals were implementing smoking cessation. And across our region of Ontario, we are reaching between 3,000 and 3,500 inpatient smokers with consultations every year. And this represented about 35% of all expected consultations, expected smokers. So the performance, remember the target was 80%, the performance at baseline was about 35%. This dotted line is when the policy came into play in 2010. And you'll see once that policy was in place, then we were really rolling. And we almost doubled the number of consults or smoking cessation interventions that took place for inpatients by 2013. So you'll see, we went up to 6,800 smokers receiving an intervention, which represented 63% of all expected smokers. So we didn't quite reach our 80% target, although 4 or 5 sites actually were reaching 80%, but on average, we were at about 63% performance. From a statistical standpoint, now you don't need to be a statistician to see the difference. There's quite a difference before and after, but there was a significant slope change, and that's what interrupted time series design measures, is the change in slope of the 2 lines before and after. And we saw a positive slope change, which represented statistical significance. So now that brings us to our maintenance period, what was nice is that the Champlain-Lynn actually left those targets in the agreements with hospitals after 2013, and we did see sort of a maintenance of that performance beyond, but of course everybody worked really hard to get their best performance in 2013. When we looked at effectiveness, we didn't expect to see a difference in the proportion of people that quit smoking before and after, but you'll see in 2009 compared to 2013, there was no difference in sort of the proportion of patients who were smoke-free when we evaluated their quit rates. But remember this equation of impact being effectiveness times reach. What this really showed is the impact of this policy had on reaching more people, but really generating more quitters in our region. So we saw an increase of about 1,300 quitters per year, just based on the increase in the number of consultations or support that we were providing people. And so that to me showed the real impact. And then going back to our data linkage study, and remember the numbers needed to treat, we only need to treat 7 smokers to prevent 1 hospitalization, and only need to treat 14 to prevent 1 death over 2 years. And so this is really where the impact comes in, is when you can reach more people and to see these types of outcomes. And just quickly, I'll tell you about some other research that we've undertaken looking at ways of increasing reach for patients. This was a feasibility study that was just published in the Canadian Journal of Surgery. And on the top there is Joe Sadek. And Joe was a surgery resident and who's now at UHN. Below Joe is Hussein Malou, and he's a general surgeon over at TOH. And Hussein and I co-supervised Joe's research project. And this was actually a Tahamo funded project. And Priscilla Belanger is at the bottom, and she was the implementation specialist working to implement and evaluate this program. And what was interesting about this study is there were two things. Number one, I'm not a surgeon, but you'll have to take my word for it. Hussein would say, you know, if you talk, he would admit, or he'd say, if you talk to my colleagues and you ask us, you know, do you address smoking with your patients prior to surgery? He said, we'd all say, yep, we address smoking with all of our patients. So that was sort of the thought. But when you ask about implementing smoking cessation in a busy surgical outpatient clinic, one of the things we realized is that we really had to adapt the model and make it super brief, super simple, and align with their sort of existing practices. And their practice was, you know, if they're general surgeons, so if they're going to be treating someone for gastrointestinal surgery, that's what they're focusing on during their appointment. If there is another condition that the patient may have, their practice would be, I'm going to refer the patient to the clinician who specializes in that condition. And so that's sort of how they wanted to do smoking cessation. We'll identify smokers, we'll advise them to quit for their surgery, we'll give them prescriptions for medication, but we want to refer them to the smoking cessation specialists. And taking it a step further, we wanted to evaluate an opt-out referral. So leading up to this, typically how the Ottawa Model follow-up works is that we ask patients, would you like to be referred to follow-up support? And patients can either opt in or opt out. What we tested in this study was kind of flipping the narrative and saying, the surgeon would say, I'm going to be referring you to follow-up support. And if the patient did not decline, they would put in that referral, and our smoking cessation nurses would call the patient back and enroll them in follow-up counseling. And so it's a minor nuance, but it was really important for us to test this and see, will that increase the number of smokers that ultimately engage in smoking cessation support? So what do we find? We conducted post-clinic interviews with patients. So when patients would leave their appointment, we had medical students actually there who interviewing a consecutive series of patients to say, did anyone ask you about your smoking today during your appointment? And for smokers, they were then asked, were you offered tobacco treatment? And remember, most surgeons responded initially that they thought they addressed it with everyone. Well, what our study found is that actually, before the protocol was implemented, only 8.6% of patients were actually being asked about smoking. And among the smokers, 0% in our study were offered any sort of smoking cessation treatment prior to their surgery. Then we implemented the protocol with this clinic, and we found that after implementing the protocol, 86% of patients were asked about smoking, and 70% of smokers were offered a tobacco treatment intervention. And when we look at our intervention group in this case, there were 164 identified smokers in the post cohort. And 70% of those, as I mentioned, were provided an in-clinic intervention by the surgeon or nurse. 87% were referred to counseling using the opt-out approach, and 53% went home with a prescription for a smoking cessation medication. Of those referred to counseling, 83% actually participated in that counseling. And this is compared to in our standard program, when we use an opt-in approach, only 20% of smokers these days engaging or choosing to enroll in follow-up support when using that opt-in approach. So that was pretty promising. We're going to be applying this opt-out approach in a project that we just got underway this year. So we applied for Health Canada funding and received a $3 million grant to develop tobacco treatment hubs in 7 other regions in Canada. So you can see the partners on the map here. And what we'll be developing are hubs like we had here in the Ottawa area, where we can really use that specialized smoking cessation clinic for those high-risk smokers, and using opt-out approaches to getting patients referred to this type of smoking cessation support. So more to come. This is year 1 of 5 on for the Connect project. Okay, it's time for a little poll. So we'll see who's, if those of you who are able to, you know, you're on your computer, and if you're able to I guess, participate in this poll, Kelsey's going to put it up. So the question is, when you receive gift cards, do you use them? Yes, I always use them. No, I don't usually use them. I often lose them. Or 3 is, it depends on what it's for. So if you can put in your answer and hit submit, and we'll give you a few seconds to do that. Okay, give you a few more seconds. I don't know if the poll is working. Kelsey, how's the poll going? There we go. Okay, so 52% of you always use your gift cards. 3% say, no, I don't usually use them. I often lose them. 45%, that was the camp I was in, say, well, it depends on what it's for. And so let's go through here. So this is US data, and this is a little bit old now, but consumers spend over $130 billion on gift cards annually. And actually, only 1 billion goes unspent. Well, 1 billion is a lot of money, but that's actually less than 1%. So I was actually quite surprised. So kind of in line with what we found in our poll here. So thanks everybody for taking part. So what does gift card have to do with what we're doing? Well, they have to do with barriers to smoking cessation. And when we ask smokers what the biggest barrier is for them quitting smoking, the number one thing that comes up is cost. And this sounds a little bit contradictory, or it doesn't seem to quite make sense for anybody who doesn't smoke, because of course smoking has a cost. But quit smoking medications are also costly, especially if people are to use them over a long period of time to really help them sustain smoking cessation. And our data shows that 50% of our patients who smoke are in the lowest 2 income quintiles. And so these often are not people that have extra money hanging around to be able to afford the treatment. And universally, smoking cessation medication is not covered in Canada. So in 2016, we had an opportunity to apply for some pilot funding, and we actually received close to $3 million to be able to implement the Quickcard project. And what this was we developed these Quickcards that we could hand to patients. They were like gift cards. They could take them to any pharmacy in Ontario and redeem the card for nicotine replacement therapy. They could only use the card to purchase NRT. It was specific drug information number that was programmed into the card, and pharmacists would just process the card like they would any sort of group benefits card that they get. So this was super slick, super easy. You hand a patient the card, they can go to the pharmacy, and bada bing, bada boom, they have NRT, which was amazing. I'd like to give a shout out to Natalie Martin, who was with us for the first 6 months of this project, and she really got the the dissemination plan, the redemption plan, and the evaluation plan for this project started way back in 2016. So what were the results from this massive pilot project? Well, in a 2.5 month period, because we had to spend the money within 1 year, 5,700 individual smokers received a Quickcard from one of 90 Ottawa Model sites in Ontario. 4,000 cards were redeemed. And so that's 70% of all of the Quickcards, so a high redemption rate. As far as our evaluation went, we wanted to know what impact that this had. So we called 2 groups of consecutive participants and to complete an evaluation survey. And the first group was before Quickcards, and they received the Ottawa Model only. And that group consisted of 128 participants. The second group received the Quickcard, and that consisted of 143 participants. And what we found was in our preliminary data of 1 month quit rates, that there was significantly higher quitting among those who received a Quickcard at 1 month, both in continuous and 7-day point prevalence abstinence. And 7-day point prevalence just means that they had been quit for at least a week when we talked to them. What we were also really interested in this study is about those who were not ready to quit, because we get a significant number of patients who say, thanks for talking to me, but I'm really not ready to quit smoking right now. And we wanted to know what impact this sort of gift card was as far as motivation for someone who wasn't ready. And what we found was those who received a Quickcard were much more likely to use a quit smoking medication after their hospitalization. So they actually went and redeemed the card, 68%, compared to only 26% of patients who did not receive a Quickcard. And we saw significant, even among those people who, when we talked to them, said they were not ready to quit smoking, 32% of them were smoke-free at 1 month, and this is 7-day point prevalence abstinence. So this is sort of demonstrating that, the Quickcard might be a very good motivator at having people attempt to quit smoking. For the control group, when we delivered our 1 month telephone evaluation survey, we completed the survey, and then we asked them at the very end if they wanted a Quickcard. But before offering the Quickcard, we asked if they had any intention of quitting, and 43% of those participants changed their mind when they said they initially had no intention of quitting. They changed their mind to, sure, I'd be planning to quit once we offered them the Quickcard. So this pilot really showed us that Quickcards are an important motivator and help motivate patients to quit smoking. And this led us to the Initiate trial. And the Initiate trial received project grant funding from CIHR a 1.5 years ago now. And it really is looking at the emergency department as a venue for delivering these Quickcards, because there's such an opportunity to provide cessation in the emergency department. But obviously, it's such a busy environment that a tool like a Quickcard could be a really, really simple intervention that we could use for smokers that are visiting our EDs. I'd like to take a moment to give a shout out to these 5 individuals, Drs. Burney, Mulvihill, Reed, Cochino, and Nair. I submitted this grant twice to CIHR, and these were my internal grant reviewers. And I thank you all for your feedback and just making this project a really much better, certainly for the second round. And so thank you, and I share the success with you. So again, why the emergency department? Well, there's 3 to 4 million smokers visit emergency departments in Canada every year, but very few EDs offer stop smoking support beyond, brochures on the wall. So we felt that Canadian emergency departments were a missed opportunity in the initiation of smoking cessation. But as I mentioned, they're super busy. So if we were to put an intervention in place, they'd need to be very simple and remove patient barriers. And so we are excited to be able to test this The trial, of course, we have ethics approval. We were supposed to start this year, but as you can imagine, COVID is not a great time to start a study in the ED. But actually, we're looking to start virtual recruitment very shortly. And I'd like to acknowledge Aditi Garg, who joined our team in October and September. And she is the research coordinator for this trial that we will be collaborating with the Ottawa Hospital, Montfort, and Winchester to test this intervention in a randomized controlled trial. I'm going to wrap up because I'm just seeing the time here, but just back to the sort of story of the Ottawa Model. We've been very fortunate to have received significant government, NGO, and industry funding over the years that really helped with that initial expansion of the model across the country. And even in the development of implementation hubs in Eastern and Western Canada. So much so that we're at over 400 sites across Canada that have implemented this model. Back in 2006, we were doing great at the Heart Institute, reaching 2,000 smokers a year providing this intervention. And this just reflects data that we actually get. There are many sites that we've partnered with over the years that don't send us data anymore. But of the data we get, we're now reaching 45,000 smokers a year, a cumulative total of about 400,000, almost 500,000 Canadian smokers that have been helped with this intervention. And so it's very rewarding to have seen sort of the reach that this program has had. And I had worldwide in the title, so of course it's been adapted and adopted in many other countries across the world, in the United States, Uruguay, England, Germany, Greece, India, and it's very, very gratifying to see others in other parts of the world now adopting the model and actually doing their own research and publishing their own findings. And so that's been a real treat to be part of as well. Okay, so some acknowledgements. Of course, let's start with the founders of this model, Drs. Bob Reed and Andrew Pipe, and who I'm sure they didn't realize when they were sketching on napkins back in 20 years ago what this all would have looked like. But really grateful to them for all of their work in terms of smoking cessation. And I don't have everyone on here, but this, we do have a team of about 25 people in Ontario now who their sole focus is implementing smoking cessation and helping smokers. So to summarize, this sort of knowledge translation theme, it's really about identifying a problem. It's developing the interventions to help solve those problems. It's evaluating those and creating sort of the business case, and then adapting and expanding. And I'm really fortunate, I get to sort of apply these principles in other work that I'm doing in prevention and wellness, and also women's heart health, and trying to scale up interventions, important prevention interventions among other high-risk populations. Okay, I'm going to end with a happy International Women's Day to my team in the Prevention and Wellness Center and Women's Heart Health Center. Also to the other investigators at the Institute, incredible women investigators, and I'm really fortunate to work alongside. And of course, to our leaders, we could not do the work that we do without the support of finance and admin, legal affairs, communications, and human resources. And I could not find photos of everybody, but I thank you to all these departments. And finally, to our research services team, I think everyone's here, or no, we might be missing a few, but happy International Women's Day. Thank you for the invitation. You guys are the best, and we couldn't do what we do without you. Thanks, everyone.
Okay, great. Thanks so much, Kerri-Anne, and so that's a fantastic presentation, and very timely, and so certainly did a great job in terms of acknowledging the amazing work that women are doing in research. But I think this is a very timely from the point of view that because we were just talking about at the PI forum about the new strategic directions of CIHR. And so, this is taking a problem, being able to have a very organized approach of taking evidence to practice. and particularly building in the evaluation component, because I think using the big data, using the appropriate methodology, as you well illustrated, was critical to really bring the evidence of the impact of the practice, and really demonstrating, how cost effective it is and how effective it is, right? So I think it's really a fantastic illustration of the power of implementation science, which is actually the comment that Taisha is making as well. So this is really the importance of implementation science. And I should mention that, from a CIHR point of view, looking at the research in the future, it's not just the publication, that it comes in, sort of the number of papers and things like that, but it's really actually ultimately on the impact in the real world. And so I think it's a great illustration of that. There are other questions as well. And here's a question from Dr. Amela. And so this is an impressive work. Now, the Ottawa Model smoking cessation focused mainly on tobacco use. And so could this type of approach be, applied to other substances such as cannabis? Is this part of work in progress? And what about other health behaviors like physical inactivity?
Yeah, that's a really good question. I think the model can be applied to so many things, and there's two ways of applying it. There's the implementation side, the implementation science side, and the evaluation components that what we've learned through the Ottawa model, and the sort of pre-post evaluation. Even though it's not perfect, it's certainly better than not evaluating. But on the clinical side, and just those 5 components of the program, which is really the systematic identification and documentation of the condition. And then it's looking at what is the intervention and what is the treatment. So once you've identified someone with condition A, B, or C, what is the intervention? And then what does the long-term follow-up look like? And so I think it absolutely can be applied to other health behaviors, other health conditions that we're not necessarily asking about, systematically. And cannabis is a great example. We just finished, and I didn't tease it in this presentation, but we'll be publishing, hopefully, or submitting for publication over the next month or two, are the results of our cannabis survey. And that was just step 1 at understanding how many of our patients use cannabis. Well, once we know that, the next piece is going to be, well, what interventions can we offer to help people to stop smoking cannabis if that's a problem that they're facing? But step 1 is understanding how many people are doing it, and if we don't ask, we don't know anything. So that's definitely step number 1.
So really, I think very broadly applicable. Question from Jim Robley, and he says, thank you for an excellent presentation. He's actually curious, because you present some data in terms of smoking following surgical procedure, but do you have data on our own patients after cardiac surgery here at the Heart Institute? How successful is the smoking cessation in this population?
We do. We actually have we actually have a study that's ongoing, and so the results are not there yet. But we did do a small pilot that was, it was actually never published, but we tried. But it was in the PAU, and it looked at both safety and efficacy in the PAU, and we did find that there was important safety outcomes and also cessation outcomes, and for our surgical patients. Just from a program perspective, we definitely intervene with our cardiac surgery patients, and our quit rates. Like I said, cardiac patients who smoke tend to be a bit more highly motivated, especially those who are, might be their first event, and it's sort of the quote wake-up call. But nonetheless, the people who are smoking these days, I mentioned that the generally in the population, the quit rates are going down. But those who are left smoking typically tend to be those that are super highly addicted. And so even though they had a cardiac event and they might be motivated, it doesn't mean, I mean, at the end of the day, it's an addiction, and it's a very, very difficult addiction to overcome. And so I can share with you though, Dr. Rodley, if you're interested, I can dig up some of the findings from our NRT and the PAU study, but also see where we're at in terms of the ongoing trial with the surgical patients.
Yeah, so important data, and best luck in terms of publishing that information. Yeah, so now in view of the time, we probably will wrap this up, but I think this is a very, very important lecture, sort of great illustration of the importance of implementation science. And I think it's a really an evolving area of both research actually, by itself, as you well illustrated, and how to translate it into policy. And I think that is well illustrated in your implementation as well. And, how to evaluate these processes and the best way to actually, maximize the impact on the population. So I think this is a really very, very timely, and thanks for all the, sort of the women, on your team, and also supporting your team, make all this successful on this special day. And can't wait until the day in which we can actually get together and scratch out more ideas at Tickers. Obviously, that's where it all started. So thank you very much. Yeah, I really appreciate a wonderful presentation, and thanks so much for joining us. And so congratulations again on International Women's Day. Take care. Bye-bye.
Thank you.